How do you assess in the office, if you're a primary care, how do you assess the severity of this disease? What are the good questions? You've alluded to this early on, but why don't you walk me through this a little bit?
So in light with what we've talked about, but one of our colleagues, Dick Zawalik, actually wrote a wonderful manuscript. And you know, we have these 12 patient questionnaires, these 24 item questionnaires. He said all you need is 2 questions. How you doing? And what you doing? Okay? And he said, I'm doing fine. What you doing? Nothing. I'm sitting on the couch. I'm barely able to make breakfast anymore, but I got people doing that for me. And so, you know, those are probably the 2 most key questions in beginning to address that there's issues. And what happens when you do a little bit more? Well, I just don't feel like it. But what happens? Well, maybe I get a little bit more short of breath, but I'm just getting old, you know, and I smoke, and so. But those are the questions.
That's the old smoker's cough thing again. I smoke, I expect this. Is that it?
The other thing that I think is important to stress, and it certainly comes up with the comorbidity issue, is you can't take care, and this is why primary care is such a critical issue, you can't take care of COPD by just taking care of the COPD. You have to take care of the person who has the COPD. Almost all of them have multiple other medical issues. The COPD in some senses is the patient themselves may view it as simpler because they don't have to take the medicine if they just don't do anything. That's what you're trying to hear from Frank and Fernando and Jim and I, is that that's not the approach. People have to do things.
Wait, if I understand you correctly, you have to talk to people?
You have to talk to the people. You need to know what you have. I mean, you mentioned early on, Peter, about the fact that it's a leading cause of readmissions. But, you know, whatever the index cause of that first hospitalization, what's clear is that most readmissions are about comorbid conditions. And that's clearly true in the COPD world.
Now, we were talking, now let's get on to pharmacologic approaches for a bit. You were talking about LABAs and LAMAs. Which patients need both LABAs and LAMAs?
Well, here's where there's a bit of a philosophical difference, okay? Now, the gold criteria say, even with patients who are very symptomatic with advanced disease, you start 1 bronchodilator, and then if it doesn't resolve things, you progress. But in my experience, after seeing several thousand patients with COPD, it's never fully reversible, and I've never had a patient that I completely get rid of their symptoms or activity intolerance. And I'm inclined, except in mild disease, to start with a double bronchodilator. And early on, often not the inhaled steroid unless they have this asthma overlap or they really are already frequent exacerbators not treated. But I do tend to start with the LAMA-LABA in patients with moderate to severe disease. Now, Fernando, who's on this GOLD committee, maybe he can give us some insight into the discussion.
That fits within the GOLD components as well. Jim, you want to?
I very strongly support what Frank says. Now, I also, when I was chief, I put in clinics out in the community in a small town, rural area with much less sophisticated population than at the university. When those patients come and are short of breath, they want relief. They don't want me to screw around with clinical trials of 30 or 90 days. And having spent most of the last 20 years of my life studying the LABA, LAMAs, and the combinations, we know that there are responder rates. Some people do great with the LAMA, some don't. Some do great with the LABA, some don't. Put them together, everybody responds at least a little bit, so I give them both.
So what combinations are out there in terms of fixed dose options for both LABA?
Well, you have umeclidinium and vilanterol, that's called Inuro.
I'm glad you get to pronounce those.
Okay, that's a dry powder inhaler. We might want to talk about dry powders also. Then you have a soft mist inhaler, Respimat with Stiolto with tiotropium, a long-term excellent, and Olidaterol. Then you have Ultibron, which is Indicaterol, and glycopyrronium. Another very new, which I like a little bit, is because it's still a meter dose inhaler called Bevespi. That's formoterol and glycopyrronium. And then another one coming with Tudorza and with aclidinium plus formoterol. So you have all these different things. It's going to be based on cost. They're all very similar because when we do the dose response, we can't give you a bomb. They all have to be similar, anchored to other existing therapies. So there's no way that one is a real breakthrough. They're all very more similar than dissimilar.
So the advantages of fixed dose combination therapy are what?
Well, it's a small advantage on compliance, okay? And I actually discussed that at FDA. Actually, the numbers are only with a once-a-day drug in COPD, 47 versus 39 or something like that. So it's within 10
That's
points.
real. That's
It's real. It's real. And you wish everybody was 60 or 70, 80%, of course. But there is a compliance advantage, and we know that compliance, that's what the argument is for the generic drugs, enhances compliance, reduces exacerbations.
So there are 2 points I think that Jim mentioned that are worth stressing. Being old, I remember when blood pressure medicines were 4 times a day. When you went from 4 times a day to twice a day, it was life-changing. Going from 2 to 1, you know, that's not so clear. The other thing that I think Jim was talking about at the end, and certainly Fernando brought it up, is that it's not just about, and gold, among other things, deserves the credit, because for the longest time, you asked who got treated, it was depending upon their FEV1 level. And gold recognized, as many of us have now, that it's really about symptoms and exacerbations. And the neat thing, as Jim mentioned, is that the LAMA-LABAs not only seem to improve symptoms, but they do a pretty damn good job in controlling exacerbations as well.